Hello everyone and welcome to January Let's Code Together. My name's Jane Knight and I'm a clinical associate with the MEDRA MSSO and I'm joined today by my colleague Dr. Caroline Wilson. Together we'll take you through the session which will last for 90 minutes. The first slide just explains that MEDRA came about in the mid-1990s. It was an ICH initiative. And at the time, the MEDRA MSSO was put in place to maintain and distribute MEDRA, and the activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the regulatory authorities and the industry. The next slide is a copyright notice explaining that MEDRA is owned by ICH, as is the material that we'll use today. So if you do quote anything, you must acknowledge ICH as owners of MEDRA and the material. We don't distribute the slides, but the session will be recorded and available on our YouTube channel if the audio is of acceptable quality. We'd like to make the session as interactive as possible, so we're going to use the questions panel. If you have a look in GoToWebinar, you'll see there's a questions panel, and there's also chat, so you can see the questions and you can ask your questions that way. Sometimes it may be that we have comments and you comment on feel free to comment as we go along. Ideally, we'd all like to be in the same room, but that's still not possible. So we have to use the questions in the chat panels, and sometimes it may be if we have a difference of opinion on how something should be coded, in the interest of time we need to agree to disagree. Unfortunately, we can't take requests from you today to code specific verbatims in the session, but what we will have is a survey at the end where there will be an option for you to propose new examples or new topics that you'd like us to include. And I think the vast majority of the examples that we use now, including the sessions for today, have come from previous participants. But if you work in a very narrow therapeutic area, please make sure that your examples are of general interest. So I mentioned the polling. This is how you can join the polls, either with an internet browser or on your cell phone. And what you would do is you would go to type in the URL, pollev.com, just that, pollev.com, and you'll see the screen on the right-hand side. The username, you put JaneKnight855, and you then click join. You don't put your name, it's completely anonymous, but alternatively, the easier way is to just scan the QR code, and this will take you directly to the presentation. So I'll just put that for a minute so you have a chance to scan the QR code, and if you need the details throughout the session, they are in the chats. Caroline's put them in the chat, so I think they're there. And if you need the QR code, just let us know and I can open it up for you again. Okay, hopefully everybody's managed that. Let's move on. Where are you joining from today? This gives you an opportunity to say hello and also to test the polling. So I see we've got a number of you throughout Europe. Someone in America, United States, South Africa. Is that?
South Africa. Also Argentina.
Argentina. Bueno. Yes. Any others, Caroline, you'd like to greet?
Turkey is there. Merhaba. France, Italy, buongiorno, kalimera, to Greece.
India. So welcome,
India,
wherever you are in the world, welcome. It's nice to have you with us, and welcome back if you've been to some of our sessions before. I see a number of our familiar names in the list, so very welcome back. Thank you for your support.
Welcome, everybody.
We have a web-based browser demo account set up, so you might find it useful to have a browser accessible to you during the session. You don't have to use the web-based browser that I'm giving you here. You can use anything that you're familiar with, and you can use your own credentials if you wish for the web-based browser. If you don't have access, this is a demo that will be active until the end of this week. So if you want, these details are also in the chat. Caroline's going to put them there for us, or you can take a screenshot. So this is just so that you do have the option to have a browse at the same time as us if you want to. We want to make this session as much like a workshop as possible. Now, we've chosen examples that there may not always be an exact match, and this is what makes it challenging. Sometimes there's more than one possible approach, and even the points to consider document in places offers us several approaches. Sometimes it's the case that we see a term differently, but what we have to do overall is we make the best medical judgment decision we can. We call this a best approximation. We're looking for the best LLT. But overall, we never make assumptions. We always code as reported. Medical judgment is a balance between using coding rules for consistency, but also applying medical judgment so that we manage the risks to patients. Medical reference can help us, and you'll see that during the session today in helping us understand the examples we've selected. Sometimes it's also necessary, if the concept doesn't exist in MEDRA already, it may be necessary to request a new term is added. And you can do that through the change request process open to all subscribers. So having said all of that, let's code together. So the first example is superficial inflammation and hyperaemia after forgetting to remove contact lenses overnight. So Caroline's going to put this in the chat for you, so if you forget the text, you can have a look there. The first question we see when we look at that is the verbatim clear enough to code? And can we capture all the reported elements here, or do we need to split code it? And it is the cause, the idea that they've forgotten to remove their contact lenses. Can that be captured? Is this also relevant to code? So those are the sort of questions that initially go through our mind when we look at it. We've got the superficial inflammation and the hyperaemia. So what would you select here? Use the polling and let us know what you would select. It may be that you want to select more than one here. I see some of you are voting already, so I'll give you just a short while to digest the options we've selected for you. Any more? More of you voting? Yes, it's stable now. I'll just show the QR code again so that if anybody needs it, if you haven't logged on already, there it is. To join the poll, if you're just joining us, you can join the poll with this QR code and vote. Right, so let's see how our thoughts are. I see still changing a little bit. The most popular one there was conjunctival hyperemia, because that was hyperemia was mentioned, wasn't it, in the verbatim. Few of you've gone for conjunctivitis or keratoconjunctivitis. Medical device site inflammation is also a popular choice. Some contact lens complications, and then quite a few of you have chosen wrong technique in device usage. The numbers are small here because some of you have probably selected more than one term, I imagine, here. Thank you. So that's the final vote from our group today. So let's have a look ourselves. Let's browse. So I'm going to go now to the website, the home page, and I'll use, if some of you are newer to MEDRA, this is the link you use, top right-hand corner, web-based browser, takes us straight in. I'll use my credentials that were stored. And here we are. I'll just make that slightly smaller as well to fit the screen. So where should we start with this one? Where should we start with our browse? Well, we've got the hyperemia and we've got the the superficial inflammation in the eye, but we've also got contact lens. So I think I'm going to start with the contact lens and see where that takes us. So contact lens, let's see if we've got any terms related to contact lenses. We presented a few options for you there. So let's see what we have. We had contact lens, obviously problems with the contact lens itself, contact lens discoloration and things, but then we've got contact lens intolerance. Well, no, it hasn't been, we haven't been told that, have we? Contact lens acute red eye. What's the PT for that one? That one it has its own PT. And we can see there the hierarchy of that. We can see the information on the right-hand side about that one. It's in eye disorders. And we've got some corneal disorders at the bottom here. Let's mention that corneal disorders to contact lenses. So it seems that the contact lenses affect the cornea. Well, it would be the cornea and the conjunctiva, wouldn't it be, where the contact lens sits? So let's have a look at some of these and see. Then we could also think about, well, what's the inflammation? What would it be? Conjunctivitis, some of you selected. Let's have a search for that and see what that brings up. Superficial inflammation. Inflammation is an itis term. So let's see what we've got. We've got a lot of conjunctivitis terms here listed. I could look through all of those. We presented a few of them for you in the interest of time. So we can see we've got just plain conjunctivitis. We've got lots of infective. We don't know it's infective. We've got we've got keratoconjunctivitis down here. So this one would affect the cornea, kerato meaning cornea, and conjunctivitis, the conjunctiva. That has a PT of keratitis. And if I put my cursor on that, I can see that the preferred term keratitis is in eye disorders. And if I do the same for conjunctivitis at the top here, let's see what SOC that one falls into. That one actually falls into the infections. So it's interesting that the inflammation of conjunctivitis is seen as being infectious, whereas keratitis is focusing on the inflammation. So we can see that. So let's have a look at this keratitis. Keratoconjunctivitis. I like the look of that one because it doesn't put it into the infection SOC. It's not been mentioned that it's an infection. It's here under keratitis, and we can see the other inflammation, corneal, things like this. And I could see also that when MEDRA has some complications with contact lenses, it often mentions the cornea. So that one looks quite a good option. Let's go back to our slides and see. So one of the terms we saw there in our browse was contact lens induced acute red eye. So we've done some referencing of that to show you today. This reference we found from the review of cornea and contact lenses says that CLARE, or contact lens induced acute red eye, is an inflammatory event of the cornea and conjunctiva. So that's what we've had reported. We can see from the picture there that there is hyperaemia or redness there. General risk factors include high water contact lenses, wearing of tight-fitting lenses, and a history of recently upper respiratory tract infection. And it also says that further down that one commonly cited cause is colonization of the lens surface with gram-negative bacteria. So it's not that there's an infection in the eye, but it's that the inflammatory response is triggered by endotoxins released by the breakdown of bacterial cell walls. So having the presence of bacteria on the surface of the lens is what makes this inflammatory process. And as our patient had worn their lenses overnight, forgetting to take them out, and it says here that the condition is worsened in the tight lens environment because of lens dehydration, minimal lens movement, decreased tear exchange, and hypoxia to the surface of the eye. So all of those would be worsened overnight if you think about it when the patient is asleep. So this is a common risk. So that would seem to fit. It's not an infection. That would seem to fit quite well what we have reported. But as you know, we so often say we don't diagnose, we don't make assumptions. So some of you might be concerned there with that, well, we can't be diagnosing. So that's a consideration. So our learning points on this one is that we would distinguish between infectious and inflammatory. That's what would be in our mind we'd be looking at all the parts, superficial inflammation and hyperemia. Now, inflammation is made up of four elements, isn't there? With pain, redness, swelling, and heat. So having those four components of inflammation, is the hyperemia covered? If we were to find an inflammatory term like keratoconjunctivitis, an inflammatory eye condition, would the hyperemia be covered? Because hyperemia, redness, it would be covered by the inflammation. So that's another consideration here, considering the meaning of inflammation and whether hyperemia is part of it. And we would look for terms that could potentially capture the relationship to the contact lenses. And also, don't forget, we've got the term that a number of you chose, that we suggested perhaps we could also select the wrong technique in device usage, because they're not following instructions. They've forgotten to take their lenses out. So we mustn't forget that one also. So our final suggestions on this is that we would select either keratoconjunctivitis, or if you feel comfortable, select contact lens acute red eye based on the referencing that we've seen. But also don't forget that we would also select wrong technique in device usage process. So that brings me to the end of that example. Do we have any comments or questions, Caroline, on that one?
Yes, there was one question here from Anne-Sophie regarding the 3 criteria for classification to inflammation. So redness, the swelling.
When I learned to code, somebody told me it was, and they put it in Latin, it was calor, rubor, dolor, and tumor were the 4 I was given. I don't know, Caroline, if you want to, and that to me is pain, redness, swelling, and heat.
Yes, that's exactly, it's the Virchow's criteria.
So based on that, and where we say that if we have 2 conditions in MEDRA, one's more specific, we also have the guideline that if we have a diagnosis and a symptom, one's covered by the other, we don't need to capture both. So on balance, I would probably on this one have selected keratoconjunctivitis, but the more I referenced contact lens acute red eye, I could select that. But I know a number of our attendees are often reluctant to make to make that diagnosis. So that's why
we have another question here.
Yes.
Do we have the liberty to put a diagnosis as keratitis if the reporter didn't do so?
Well, it's not really a diagnosis, is it? They've told us there's superficial inflammation. So I see keratitis as another way of saying corneal inflammation. So if we were to have a look in the browser, we can have a look, is there a term for, let's have a look at what comes under keratitis. We have an LLT there. I think you can see that one still. Corneal inflammation is actually an LLT under the PT keratitis. So I haven't made a diagnosis. I've just converted. What I have done is I have taken the site where the contact lenses are placed over the cornea, whereas our reporter didn't say it was corneal inflammation. They just said inflammation. But by looking down, and we have this other term, keratoconjunctivitis, then that inflammatory term covers both the sites of cornea and the wider conjunctiva. That's why I feel quite comfortable selecting that term. I don't see it as a diagnosis as such, but I do take your point.
Yeah, there's another comment from Yvonne saying that at the moment the contact lens is missing. And we discussed this, Jane. I would prefer to really code this to contact lens acute red eye, because this would really not only cover the inflammation, the superficial inflammation of the eye by the acute red eye, but also the relationship to the contact lens. And it's really a very usual scenario that we see here, but because the contact lens acute red eye or glare really occurs after sleeping with contact lenses in most instances. So I would be fine with contact lens acute red eye as well.
Yes. Okay, yes, so I think that's fair. That's a fair comment, Karen. My concern, I think, was that initially I thought this was it looked like it was more severe than just waking up and your eyes are a bit sore. but it's superficial inflammation and hyperaemia. It seemed like it was something which may resolve quite quickly, and I was concerned that the contact lens acute red eye was more severe. But as I say, we talked about this yesterday. This was one of those examples where we sometimes see the examples differently, don't we, Caroline? And we discuss it.
Yeah, and Martin also says that, of course, the contact lens is somehow captured with the wrong technique and device usage process, but maybe.
Yeah. You've also got the verbatim with the details in your case. So
yeah, Anne-Sophie is also commenting that the superficial inflammation could also be of the skin, but I think this is quite improbable because it's really connected. So the patient forgot to remove the contact lenses overnight, slept with them overnight, and then detected the superficial inflammation and hyperaemia when waking up. So I think it's a valid point to code this to a eye disorder term.
It's the eye. It doesn't affect your eyelids. I know from experience on this one, having had patches of forgetting. I'm sure a number of our attendees have had this themselves as well with their own. It's more the eye itself.
Yeah.
So let's move on.
It's suggesting another LLT overwear syndrome. I don't know. Maybe we can check this one. Overwear syndrome.
My understanding of overwear is where they're wearing it for too long on a regular basis. So it's not a one-off occasion. It's more of a chronic thing. But we can have a look at that one. I'll do some research on it when you're doing your examples, Caroline, when we switch over.
Okay.
My understanding of that is it's a chronic condition. It's over a longer period. They're wearing it for too much or on a regular. This may be a one-off. Okay, so let's do the next one in the interest of time. Our next example is inflammation around umbilicus. So our question here that we raise is, where is the inflammation? When you see anything around, is it over the umbilicus? Is it the umbilicus itself? Well, no, it's telling us it's around. So that suggests to me it's more like the abdominal wall. But what type of inflammation is it? And then with it mentioning the umbilicus, the obvious question is, well, do we know the age of the patient? Is it a newborn baby? Is it something to do with the cord itself? Is there a medical synonym we can use for the umbilicus and inflammation? And is there a suitable LLT? So these are the questions that we'd be raising in our mind. Which LLT would you select? And here we've given you the medical condition, the synonym for inflammation of the umbilicus, umbilitis, and umbilitis of the newborn. So which of these would you select? We've given you the option of skin inflammation, or the synonym for that, dermatitis, dermatitis localized, umbilical cord abnormality, or would you seek clarification? I'll just give you a few more seconds. I'm looking at the numbers going up there. If anybody needs the polling details, let us know. So let's see where your thoughts lie at the moment. Mostly you're seeking clarification there, maybe to find out exactly where the inflammation or the age of the patient. Some of you have selected umbilitis. Some of you making the judgment umbilitis of the newborn, although we haven't been told that it's a newborn at this stage. Perhaps those of you who've selected that are also going to seek clarification. Dermatitis localized or skin inflammation is quite a popular one there, I see. And here's our final result. Seeking clarification, interesting there, Caroline, is the most common option people have selected on that one. So let's see. So just as a reference for you, if you're not familiar with the term, Umbilitis is inflammation of the umbilicus. So we've got around the umbilicus, and that's the thing that makes me reluctant to select this without seeking clarification. So it's the around. Let's browse and see what we can find. As I say, I'm thinking more about abdominal wall. I'm going to have a look for abdominal wall and see what terms I can find, because the around is what sticks out for me. So let's see, we've got 49 conditions that do. We've got abscess, biopsy, bleeding, closure. So I would have a look through these and see, is there anything there for inflammation? I could put inflammation in with it, because that's what I'm looking for, isn't it? Inflammation. No, nothing. So then I ask myself, well, what type of tissue is it? And that's why we gave you the option for skin inflammation, based on, is it skin around the umbilicus? We've got skin inflammation that has a PT of dermatitis. And then we can have a look at the PT there. Go to the browser. Other allergies underneath it. So it hasn't said, we haven't been told it is skin, but what can we do with it? We may query it, as a number of you said, but also choose to code it in the meantime while waiting for follow-up, if follow-up is available. So we've got dermatitis there, dermatitis of various sites, and then we have our skin inflammation that we selected there. So that's probably where my thoughts are. Let's have a look at umbilitis to check if there's anything else nearby and to show you where it's placed. There it is. There's the two terms, umbilitis and umbilitis of the newborn. And we can see, if we put our cursor on it, we come down. The PT, it's in an infections system organ class there, and we can do a right-hand click and go to the browser. So we see it's in infections as a primary, and it's got a link into pregnancy because it's common, but because of it being around the umbilicus, this is what we've got: belly button infection and umbilical cord infection. I'm not sure that's what's actually being reported here. My gut feeling suggests that I wouldn't be so comfortable. I would edge more towards the skin inflammation, being that there's nothing more specific for the abdominal wall. So our MEDRA points to consider can help us as well, here telling us that when you're looking for something, a term that you want a MEDRA term to include both the body site and the event, we capture the event more important than the site. So skin rash on chest is the example that codes to skin rash. So what's important here is that we do capture the inflammation, and the tissue would be skin, skin around. So the event takes priority. But you do need, in this case, to have medical judgment, because it may be in some situations that the body site is important. So on this one, we would be familiar with existing terms and synonyms within MEDRA relating to the umbilicus, such as umbilitis. Consider the age of the patient and any age-specific LLTs, and be careful when symptoms are reported around. And that's what I showed you. So we would prioritize the medical condition, and there I would select skin inflammation or with a PT of dermatitis. Any questions or comments on that one, Caroline?
There's one comment. Can we ask to add a MEDRA term for periumbilical inflammation?
You could ask for it. If periumbilical is a commonly used expression for it, the team that look after our change requests and decide what should be added are sometimes reluctant to add terms for vagueness if it's not a very well-established medical condition or a common finding. What do you think, Caroline?
Yes, I agree. It's too specific. I don't think that it will be accepted.
I don't think it would be accepted, but it would be a valid request you could put in. I'm not sure that it would fit with their philosophy of what would be added for future, because they try to avoid overpopulation of MEDRA with these vague or non-specific sort of terms, regional terms.
Yeah, there's another proposal here, and it's valid. Why not assigning dermatitis localized? It is mentioned that it is around, so it's a localized reaction.
Yes, because dermatitis is the PT. I was thinking that when I was in the browser, because we gave that as an option in the multiple choice, didn't we? And then I wasn't sure if I'd imagined it and if the term existed. I had a bit of a funny moment there when I was doing my browse. Let's have a look together. Dermatitis localized. I don't think there is actually one there. I don't know where I got that from, Caroline, when I put it in the poll. Is there a localized dermatitis?
No, there's an inflammation localized inflammation. But this could relate to any body site, not or.
I'll show you the placement.
Structure.
Yes, that's the difference with this one. Inflammation localized, it looks good at the LLT level, but we're losing the skin. And then at the PT level, we lose both the skin and the localized. So that then becomes a very non-specific PT. It's not telling us much at all. That's why we preferred skin inflammation, because we then keep the skin inflammation at the PT level. Okay, on that, shall we move on? The next example is anorectal inflammation, another inflammation term. Now, what's the site of here? What's the site here? Anorectal. So it's the region, the anus and the rectum together. Can we find a term which is site-specific for this inflammation? And if we can't find that site, what do we do here? Remember what we just saw in the points to consider guidance, that we look for the condition over the site if we can't find it, but we need to use medical judgment. Can we look for a more general term, or can we prioritize parts of the reported term? Is part of that site more important, or do we split it and select two LLTs? These are the questions we'd be asking. So another multiple choice for you. What would you do here? We've selected some to give you the options. We've got intestinal inflammation, colon inflammation, rectal inflammatory process, anal inflammation, periproctitis, or would we ask the reporter to split it? How are we doing here? I see a few of you voting. I'm not sure that there's as many of you voting as sometimes today. I'm looking at the numbers, so I hope everyone's okay and you've managed to log on all right. If you're having problems, let us know. I like to see people involved and in voting. So let's see where your thoughts are so far. Anal inflammation is our most common, most popular choice of that selection there. Rectal inflammatory process, quite a few of you, or periproctitis, and some of you would ask to split. 50% of you there now selecting anal inflammation. So let's see, that's our final choice from the group. So let's have a look at what we find. If we look in the MEDRA concept descriptions that you can access from the browser, it defines lower gastrointestinal tract. And it says here, for the purposes of coding, the following constitute the lower GI tract. So we've got the small intestine, the large intestine, and the cecum, the colon, including all parts of the colon. Then we've got the rectum and the anus. So it would all be considered lower GI tract if that was the sort of grouping we were looking to select. So we could use that information when we browse. When we look at the hierarchy, so one of the things you can do in MEDRA, if you have these sort of sites, anorectal, you can look at other anorectal terms within the terminology and see how they're placed. So here we've done that. If you have a look on the left-hand side, we've done the search already. We're showing you the terms we found that are anorectal. And on the right-hand side, we've selected 5 of those and showing you how they're placed as they go up the hierarchy. So we see that sometimes there's an anorectal term at the PT level, like cellulitis, the second one down. But sometimes we can't, the PT prioritizes, and it seems that it prioritizes the rectum. So we've got anorectal abscess, which goes to the PT of rectal abscess. The same with herpes simplex, which goes to proctitis. So proctitis being synonym for rectal inflammation. And the same there with the bottom one, anorectal pain, which has a PT of proctalgia. So that's a good guidance for us that if we're not able to capture the combination site, then we could select a rectal term to make up for it. So here let's look at Dorland's. Dorland's defines anorectal as pertaining to the anus and rectum, the 2 areas. Anorectitis is inflammation of the anorectum, so that's something we could look for in MEDRA. And then we've got proctitis as inflammation of the rectum, and paraproctitis, inflammation of the tissue surrounding the rectum and anus, surrounding. So it's that around again, a bit like we just saw with the umbilicus, but it's not just the anus and rectum there. So that's considerations before we then go and browse. So let's go and browse and see let's look first of all for anorectal inflammation. No, there's nothing there with that. So let's have a look at rectal inflammation and then browse around. So let's start bottom up and then have a browse at what we can find. Rectal inflammations is an HLT, and then so rectal, let's have a look at proctitis, because that was what Dorland's defined rectal inflammation as. Proctitis. So there's our LLT of proctitis and with a PT. So let's go to the browser and have a look at this one. And we've got also some terms containing it. So long as there isn't an there's coloproctitis, so the colon and the rectum. There isn't an anoproctitis there. There's periproctitis and paraproctitis that we just saw. Those are both also linked to proctitis. So the tissues around it. Let's go to the browser and look at all the LLTs under the PT of proctitis. There it is, proctitis, our PT. We can have a look at the LLTs, and I would select, based on what we've seen so far from Dorland's and from the placement of other anorectal terms, I'd be looking to select one of these. The closest matching one with the wording would seem to be actually this one that we didn't think about. Rectal inflammatory process. That was one we gave you in the multiple choice. And I think on those, that's the one that I would favour. So we would look at possible terms, as you've seen us do with anus and rectum. We'd look at the hierarchy, look at other anorectal terms, use our medical dictionary. You saw the references from Dorland's, and I would prefer rectal inflammatory process with a PT of proctitis, or alternatively, if you weren't happy excluding the anal portion, you could also select anal inflammation as a second LLT, if you felt that was appropriate. Any thoughts on that one?
No, there's no questions, but there's one comment from Martin that surprises me, because it says possibly people do not vote as much as the list of verbatims wasn't sent before the webinar. So they haven't had the chance to prepare and feel less confident to vote.
Out? Did you not receive them, Martin? Maybe, did anyone receive them? Oh, I'm sorry if you didn't, because we...
Oh. No, Yvonne is saying she received it, so...
Oh, so some of you did, some of you didn't. What I didn't do this time... So I'll move on in the interests of time. I'll pass over to you, Caroline, if there's no more questions. And while you're just logging on your screen, I'll explain. What I didn't do this time was I was keeping a list of people who'd attended our previous months. But as we started a new year, I thought I'd start a new list, and because otherwise there might be people who've moved on and don't want to join anymore. So that's why I don't want to be hassling people months on months. So that's why I thought, rather than just sending to people who maybe attended 6 months ago or a year and don't want to join anymore, what we need, I think, is a sort of a membership list, don't we, of people who opt in, they want to receive. So we sent it out to people who registered for the webinar, but not previous attendees this month. So I'll hand over to you, Carol-Ann. Thank you for that.
Okay, so in our next example, a peptic esophagitis is reported. So do we clearly understand the meaning of the reported term, or do we have to query? And can we capture the full information with just one combination term, or do we have to split code? Here again, your turn. Which LLT or which LLTs would you select? Acid peptic disease, esophagitis, reflux esophagitis, digestive enzymes increased, or esophageal pH increased? What would you do? Let me show the QR code again, because somebody has asked for it. Here it is. Just scan it with your cell phone, and then you should be brought directly to the poll. So I see that plenty of you are voting already. So let's see where you're going to. So esophagitis is the preferred options, but others also vote for reflux esophagitis, acid peptic disease. Here you would of course lose the exact localization of the disease, and others would also code the digestive enzymes increased or esophageal pH increased. This is our final vote, so let me close this poll now and look into the door lens. So what does peptic mean? It means it has to do with digestion or other actions of the gastric juice. And peptic esophagitis is a synonym for reflux esophagitis. And a reflux esophagitis describes the fact that gastric juice flows back into the esophagus, causing damage to its mucosa. And this may be associated with erosion and ulceration, and in serious cases also scarring, stricture, and perforation may occur. So this is an image for this disease, obviously with ulcers. Now let us check in the browser. Here I have to log in again, it kicked me out. If I search for peptic, I find some terms. As a peptic disease, somebody was voting for that, but this is a more vague term. It's grouped under gastrointestinal, but it doesn't specify the specific site in the gastrointestinal tract that is affected. So we also have, what have we? The peptic duodenitis, for instance, and this is just grouped under duodenitis, showing that the attribute peptic makes no difference on PT level, at least in this instance. So let me do a top-down search in gastrointestinal disorders to see whether we find a suitable term. Here we find HLGT, gastrointestinal inflammatory conditions. So here we have the esophagitis, excluding infective, but we don't have any PT that would relate to the peptic aspect. So it's just esophagitis, chemical, hemorrhagic, radiation, lymphocytic, immune mediated, or eosinophilic. But if I now look for the synonym, reflux and esophagitis, and search, then of course I will find a suitable term. Here it is, reflux esophagitis. Here it is, under gastroesophageal reflux disease. So this would be a perfect match, also based on the definitions that we saw in Dorland's. Go back here. As a general rule, when not finding a direct match for the reported condition, perform top-down and bottom-up searches in the browser to explore the MEDRA hierarchy in order to find a suitable term. And also refer to medical references to better understand the reported condition at first, but also to find potential suitable synonyms that one could use for the searches. And here's our final suggestion. We would code to reflux esophagitis under Peptic gastroesophageal reflux disease. Any questions, Jane?
No, no questions on that one. Let me just check. Nothing's come in. No. Peptic. Oh, there's one here. Peptic esophagitis could be induced by inlet patch. It doesn't necessarily mean there is reflux included.
But this is, you see, it's, you saw it in the. Let me go back to the. Here we have the reflux esophagitis. Go to browser, and here you see it's under the HLT, gastrointestinal atonic and hypomotility disorders, because it's a weakness of the sphincter. So it really represents the condition. Also, there is non-erosive disease, reflux disease, acid reflux. Here it is. So it really represents the reported condition. It's always nice or helpful to look into the LLT content of PTs in order to reassure yourself that the selected PT really represents the reported condition.
Thank you, Caroline. No other questions.
Next one. A swelling on the right foot is reported, and I'm sure that you quite frequently encounter similar verbatims in your daily coding practice. So do we know from the verbatim which anatomical structure of the foot is affected? And can we use synonyms to capture both the condition, the swelling, and the affected body side? Or should we use a more general term instead? What shall we do? So please use your browser here and enter your suggestions. Swelling on right foot, on the foot. It's not a swelling of the right foot, but on the right foot. Swelling of feet. Yes, here you cover the swelling and also the affected body side, the feet. Unilateral leg swelling would capture the singular, but this could mean that the whole leg is affected with a DVT or so. Swelling of limb, swelling of feet. So everybody is going for the swelling LLTs with some differences in terms of the affected body side. Most of you are voting for swelling of feet. Thank you for joining. So the causes for the foot swelling can be very different. If the whole foot is affected, the swelling can be caused by venous insufficiency, DVT, cardiac, renal, or hepatic insufficiency, also pregnancy, medications, and all many other diseases. If only a part of the foot is affected, and we are told on the foot, so it seems that only a part is affected, this could be due to a burn spur or ganglion cyst or tendonitis, a stress fracture of the metatarsal bones, dorsal compression syndrome. Again, quite a number of diseases, events that could lead to such a swelling either on the foot or any part of the foot. So let us check again what options we have for the reported condition. Swelling on right foot. Most of you have voted for if I enter foot, I won't find anything. The singular is not available. It's the swelling of feet that is available. So this would mean it's a plural term, but at least we would capture the affected body side, the foot. But it's a plural, and only one was affected, and that's why your proposal to code the unilateral leg swelling is also valid. Let us check what other LLTs are available under this PT. Maybe there are some that we could use. Here's the unilateral leg swelling as well, swelling of feet, swelling of legs, swelling of limb, again here, but here also the arm could be affected, so this would be too vague. So unilateral leg swelling would be an option, but it would really mean that more than the foot is affected. So swelling of feet seems to be a good solution. But it was reported that the swelling was on the foot. We could also consider skin swelling as a coding option. So let us check whether there's a skin swelling term, especially if we don't find a suitable term for swelling of a specific body site, and it's reported as on this body site. You could also consider skin swelling as an option. Here it is, skin swelling. But in our instance, it must not be the skin that is swollen. It could also be the subcutaneous tissue or soft tissue as well, or it could just relate to a bump on the foot. So a bump on the foot, we could look for a lump and either leg or limb. Nothing. Extremity. Always use synonyms when searching for, not making typos, because otherwise you don't find anything. Nothing. Let's exchange this with mass. Mass is also a very vague term, like swelling is. Here we have the upper extremity mass. So this could also be an option to look for mass terms if you don't find a suitable term for swelling conditions at specific body sites. So what other options we could choose from? Can we replace swelling by edema, for instance? If I look for foot and edema, here we have the foot edema. It's under edema peripheral. Here we have, it's grouped under, here it is. Here we have the hierarchy is grouped under general disorders and administration site conditions, primary SOC, but also has secondary linkages to cardiac disorders and metabolism and nutrition disorders. It's grouped under total fluid volume increased, because the term edema describes a swelling due to the presence of an abnormal large amount of fluid in the intercellular tissue spaces. So usually referring to the subcutaneous tissues. It may be localized as from venous obstruction or lymphatic obstruction, or systemic as from heart failure or renal disease. So it's a much more specific term than just swelling. And another option always, and we had this with the dermatitis example already, would always be to look for local swelling. If you don't find a suitable term, here it is, local swelling. It's grouped under general signs and symptoms. So this would also be an option. But here we have found a suitable term under PT peripheral swelling. So because it's really good practice to keep as close to the verbatim as possible, we should capture the swelling as basic medical concept. I just wanted to show you what you can consider as alternative options for coding if you don't find a suitable term for the respective body site that is affected by the swelling. So here we are. The slide shows the hierarchy of the relevant terms. Just as a reminder, you see that peripheral swelling is grouped under the primary SOC general disorders and has a secondary linkage to cardiac disorders. The peripheral edema, PT, has two secondary linkages, the additional one to metabolism and nutrition disorders, and the skin swelling just to the skin SOC. It's uniaxial. Here are the learning points. Keep as close as possible to the verbatim. So in this instance, capture the swelling as the underlying condition. The on-the-body verbatims are sometimes really difficult to handle, and it may be useful to define internal coding conventions to ensure coding consistency for these terms. As an example, you could ask to code similar verbatims to skin swelling if no suitable term for the affected body site is available. And you may also define rules when swelling and edema can be replaced. In all instances where no suitable term is available to capture the affected body site. Just as an example, one could define that edema can be replaced by the more general term for swelling. But of course, swelling cannot be replaced by edema because edema represents a more specific condition, as mentioned before. We would suggest to code to LLT swelling of feet. So this is what most of you, the majority, has voted for, but you could also decide to code similar terms to skin swelling, depending on your coding conventions. Any questions, Jane?
No, only one question about the unilaterality. Is that important for the diagnosis?
Yeah, I think this is product specific. It could be, but on the other hand, it could also be relevant to really capture the fact that only part of the leg is affected. So this is, I think it's both is valid, both approaches are valid, swelling of feet and unilateral leg swelling. I would prefer the swelling of feet here because it really captures the foot, although it's a plural term, but you could also decide differently. Again, this could also be something that needs to be defined in coding conventions. Of course, in this instance, it's not really relevant because it's the same PT, but in other instances, plurality, of course, or unilaterality is of relevance in instances of paresis, paralysis. Here, you would be very strict in classification, but here it's not as relevant.
So a couple of comments here. Martin's saying that laterality is important in some conditions, like when you suspect a stroke, and that's true. It's the same when we request new terms to be added to MEDRA. You wouldn't get laterality in new requests, except if it's things like strokes or heart or...
Yeah, exactly, when it's medically relevant, yeah.
Another comment from Marati, the labelling should be done with the LLT in this case.
I think labeling usually is done on PT level with only a few exceptions. It's a peripheral swelling anyway. It's either it's the leg, unilateral leg swelling or swelling of the feet. The PT is the same. So you could really use the PT for labeling purposes.
And then there's just a comment about the use of localized, but you've explained that the peripheral swelling captures at the PT more, whereas localized swelling doesn't.
Yeah, localized swelling is just under PT swelling, so it's a very, very vague term, so it doesn't capture any site, and on PT level also doesn't capture the fact that the swelling was only localized.
That's all the comments and questions. Thank you, Caroline, on that one. Thank you.
Mm-hmm. Next one. Here it is reported that there was an abnormal ECG, RBBB, and T-wave inversion. Is this clear enough to code again? Is the abbreviation RBBB unambiguous? And how can we capture all elements, or do we need to split code again? Which LLT or LLTs would you select or would you query? Abnormal ECG, RBBB, T-wave inversion. Would you select abnormal ECG and or RBBB and or right bundle branch block or T-wave inversion, or would you seek clarification here? So see, a lot of you have been voting already. Let's see what, so most of you would code the abnormal ECG, but also the T-wave inversion, and some of you would select RBBB and others the right bundle branch block. But 6% also would seek clarification from reporter. Let's close the poll here, and again switch screens to search in the browser. So if I enter RBBB, you will see that you find a direct match here, RBBB. It's not a non-current LLT, so it's really a valid LLT. It's not ambiguous, and it's grouped under bundle branch block, right? Because this is the abbreviation, right? Bundle branch block. T-wave inversion. Let's search for this one. T-wave, Q-wave MI. Where are the T-waves? T-wave inversion, here it is. Under PT electrocardiogram T-wave inversion. So we find, and what about the abnormal ECG? This is all that was reported. Here we have it, abnormal ECG, electrocardiogram abnormal. So can we assume at first that the T-wave inversion is caused by the RBBB, so that it would be sufficient to code the RBBB only, because a right bundle branch block can be associated with the T-wave inversion. But the T-wave inversion may be caused by other cardiac conditions as well. Most frequently, T-wave inversions are caused by coronary artery disease or myocardial infarction, but also by ventricular overload and ventricular hypertrophic cardiomyopathy. It may be caused by myocarditis and pericarditis, or also by pulmonary embolism or athletic heart syndrome. So a lot of conditions that could really cause a T-wave inversion, meaning that the T-wave inversion could indicate a different cardiac problem here and should not be subsumed under the right bundle branch block. Let me switch back to my presentation. Here we are. Another question is whether we have to code the abnormal ECG in addition, and most of you voted for this LLT. The PTC guidance for MEDRA term selection provides guidance for such scenarios. If two conditions are reported in combination and one is more specific than the other, select a term for the more specific condition. In the examples provided here, no investigational findings are mentioned, but in my view, this guidance can also be applied to reported lab findings or other investigational findings. The reported abnormal ECG is really very vague, and therefore I would code to the specific abnormal ECG findings only. What can we learn from this example? First, make sure that any reported abbreviation is unambiguous. If it's ambiguous, then you have to query. And if a vague condition or investigational finding is reported together with more specific related information, like here the abnormal ECG with RBBB and T-wave inversion, then ignore the vague part of the verbatim and code to the specific reported findings only. And our final suggestion is to code to the LLT RBBB under PT bundle branch block right, and LLT T-wave inversion under PT electrocardiogram T-wave inversion. Any questions, Jane?
No, just a comment from Kirsten, that what you were saying about should we capture the T-wave inversion separately, because she was saying that she found references saying that the T-wave inversion can be part of the right bundle branch block.
Yes, that's what I mentioned. It can be a sign of the RBBB as well, but there are many other cardiac conditions that could cause a T-wave inversion as well. So that's why you cannot be sure. It's not pathognomonic. It's not specific for an RBBB. So that's why, to be on the safe side, I would code it separately here.
Yeah, that's all, Caroline. Thank you.
Okay, then I give it back to you then, Jane.
Thank you very much. Let me go back to my slides. Thank you. And then I'll get back. Thank you. So our next example is, we have 3 terms now that relate to COVID. Based on requests, we had to cover more COVID. Here we have a positive serology to COVID without symptoms. So our questions here is the reported verbatim clear enough, as we always question? Does it describe an investigational finding or a diagnosis? So the fact it mentions without symptoms, does this mean it's telling us a diagnosis? Or are we focusing on the positive serology to COVID, which would clearly be investigation result? But what do they mean by positive serology? What type of test is this? That's our first initial questions that we have in our mind. So what would you code this one to? And apologies if you didn't get the terms in advance. With these sessions, if you don't receive the terms, if you've registered in the future and you don't receive them a few days before, send us a quick email to the help desk and I can assist you. Something must have gone wrong. So we've got a mix already here in our suggestions. COVID-19 serology test positive. Looks like a nice match, doesn't it, to the verbatim? Some of you are also capturing the asymptomatic portion there by coding asymptomatic COVID-19. But this is something that we'll discuss shortly. Is it appropriate to select a term like that or not, given that what we have reported is COVID-19 serology? I think predominantly you're focusing on the lab test. Here, a laboratory confirmed SARS-CoV-2 infection without symptoms. Laboratory confirmed the infection there. Somebody's suggesting it's a SARS-CoV-2 antibody test and asymptomatic. So let's have a think about this. So we've got the point in time is important here when we think about when is the test being done and what does that serology test tell us? Mostly you're going for a COVID-19 serology test or a COVID test. So what are our options? Well, is it a diagnosis? They've told us it's asymptomatic. And as some of you found, we do have a term now for asymptomatic COVID-19, which is in the system organ class of infections. We also have an LLT of suspected COVID-19. But is this a lab result? What is it telling us? Primarily, it's a lab result, isn't it? It's not telling us that they are positive for COVID-19. They're telling us there's no symptoms. So let's have a look at the MEDRA. Let's have a look at the MEDRA terms and see what we've got, what we can do here. So let's have a look at the tests first. So let's have a look at COVID. I'll do positive and we can have a look at the tests that go with that. Let's find them. So we've got some COVID tests here. I'm going to just test it. I'm just going to take this bottom one because I want to get over quickly to the portion. You could do it top down. I've just done it this way for speed. So we come down, we'll find our COVID test, SARS-CoV-2. So when we come down here, we've got one, just to point out to you as we scroll down, there is a test of coronavirus test positive and coronavirus test negative. We covered this a year ago. Last January we did this. So just as a reminder to you, Coronavirus is less specific. We don't use those when we have COVID reported. We know that it's SARS-CoV-2 because there are various types of coronavirus. So just a comment that I'm skipping over that one. I'm not even considering it. And luckily nobody mentioned that one in the suggestions either. So let's come down to SARS-CoV-2, which is where our COVID tests are. Here they are. SARS-CoV-2 test positive is the PT for all the COVID-19 test results. So we've got some different types of SARS-CoV-2 here. We've got antibodies, RNA, and just the test. So the test is a less specific one. We can open it, there's SARS-CoV-2 test positive. It tells us we've got the antigen test, the PCR test. So the PCR test is the gold standard, isn't it? The PCR test, we know that that's detecting genetic material of the virus. That's the most specific, the PCR. That's when the infection is active. Then we've got antigen tests. We've got those listed as well there. These detect proteins from the shell or the envelope of the virus. Less sensitive. Sometimes we see these as the bedside tests. The quick tests, less specific. But if we look up, we've got some other tests here, and we've got these antibody tests. Some of you mentioned antibody when we asked you. And when we have a look here, we see we have one, COVID-19 serology. And here, so what the antibody test is telling us, this is capturing the patient's immune response to a previous COVID-19 infection, that they've had the infection and there's been long enough elapsed that they've developed antibodies to it afterwards. So the fact that it's been reported that they're asymptomatic, I'm not concerned that they may have COVID active at this point in time. So I would be reluctant to code a diagnosis of asymptomatic COVID or suspected COVID, because it could have been that they don't have symptoms today, but previously they have had symptoms. So I wouldn't make that assumption that it is asymptomatic or that when they had it, it was asymptomatic. Like most of you, I would focus on what we're being told, which is the test, the result of the test, looking for the most specific. And we can see by the LLT and PT relationship that serology test is an antibody test, and it comes under SARS-CoV-2 with the COVID-19 terms. So COVID-19 serology test positive. So that's and here, just to summarize that for you, I've put the screenshot so you can see the 3 types of tests are all represented there in the MEDRA browser, and we don't select the coronavirus terms because there are various types of coronavirus, not just COVID. So our learning point there is that we would check hierarchy to verify COVID can be considered unambiguous. As well, that COVID are we happy with COVID-19, that COVID-19 is the only COVID? Well, I think that's what we are generally seeing at the moment, and that's what we would select. We would distinguish between diagnoses and investigational findings. And as we know, the points to consider document tells us clearly if something is reported as a lab result, we always code it as a lab result from the investigation SOC. We don't make a diagnosis. And we would be clear about the terminology used for microbiology and serology. And I've explained that to you briefly there as well. If you're interested in a similar term, we had a similar term, as I mentioned, a year ago. So it was January of last year. It was our 3rd Let's Code. If you weren't with us, you can listen back on YouTube for a similar one. And we've explained as well at that time. So I would select COVID-19 serology test positive. It's the closest to what's been reported, and we're not making any assumption about when the patient had the active infection and whether they were asymptomatic or not at that time. Any comments on this one, Carol-Ann, or anything you'd like to add? You presented it last time.
Just one comment from Martin saying that, of course, you have a positive serology test not only when you have suffered COVID-19, but also after vaccination, hopefully.
Of course, I forgot that. Sorry, I was focusing on the symptom part. Yes, exactly. You're right. Sorry. It's an immune response, isn't it? Thank you, Martin.
Yeah.
I forgot that. Mental. Any other thoughts or comments or anything to add, Carol-Ann?
Nothing else.
Good, thank you. So our next one is how to code Metrorrhagia considered possibly related to COVID-19 vaccination. So we've included this one because it was suggested. We receive a number of change requests asking us to add specific symptoms post-vaccination. And this is generally something that we don't add. We can't add every possible symptom post-vaccination. So we receive questions to the help desk asking us how to code them. So here, first question again, do we have to query? Can we find a term, as most of you want to these days, to capture the relationship to the vaccine? And can we find a combination term that would do that? Or do we split code it? So we've got Metrorrhagia, maybe not one of the most common really reported problems post-vaccination, but considered possibly related. So what are we going to do here? Here are a few presented for you, a few options. What would you select here? COVID-19 vaccination, adverse event following immunization, immunization reaction, post-vaccination syndrome, vaccination complication, or Metrorrhagia, or a combination of those. So let's have a look at where your thoughts lie so far. Metrorrhagia is the most common one, and I'm really pleased to see that because that's the specificity of the problem that's been reported. A few of you would choose adverse event following immunization, and we'll have a chat about that one shortly. And some of you would code the COVID-19 vaccination, which of course it's important that that is captured somewhere. If it hasn't already been captured, we would code it. And then a few of you are selecting the more general terms like vaccination complication or post-vaccination syndrome or immunization reaction. So I've got a couple of things to share with you here. One is, here's our final scores of what you've selected. Thank you for your participation. This is a slide that we used last year. So again, January last year, if you want a refresher, if you weren't with us, just explaining what an adverse event following immunization is. And these are categorized by the WHO in their documentation, that it's any untoward medical occurrence following immunization, not necessarily with a causal relationship to the usage of the vaccine. It may be an unfavorable or unintended sign, abnormal lab finding, symptom or disease, so not necessarily causal. So this would be an adverse event following immunization. So we have a few types. The first is where the individual has a response to something about the vaccine. It might be something that's very common and almost regarded as normal as the immune response develops. Or it may be something that's caused some kind of injury, caused as a reaction to the product itself, or a quality defect in the product. It may be something about the product that's causing this. So these are what we'd consider related vaccine reactions, something caused by the vaccine. Then we've got immunization error-related reactions. These are our preventable things, our medication errors, and we won't go into that today, but things that could be an adverse event following immunization, but not actually causally related. That's not relevant to this case. Then we've got the anxiety-related reactions, immunization anxiety-related. Now they're called immunization stress-related response, the new term for those kind of conditions, not related to the vaccine, but to fear. So something triggers it. That might be a case here with if somebody's very anxious and they've heard that it could affect their menstruation. It's possible, I suppose. And then you've got coincidental events, which it could be that this is just a coincidental event, or that we're told that it's considered might be possibly related. So we don't know. But that just gives you an overview of what possible events could happen and their relationship to a vaccination. So then I want to just point out to you that we found a reference from the FDA explaining their vaccines database, and the purpose of vaccines reporting and their database is to detect possible signals of adverse events associated with vaccines. So as we're looking at signal detection, in order to do that, they collect and analyze information from the reports that occur after administration of vaccines. So in order to do that, we need to capture the specificity of the condition. So I think having that in the back of your mind, well, what's the overall purpose of this? And this is to do signal detection. And if we code things to vaccination complication or adverse event following, then we're not going to learn anything, are we? We're not going to see at that aggregate level of data what might be happening. So this is something to bear in mind. So let's browse now back to the browser and see what we find here. So we can have a look at the vaccination reactions. I can go top down for these. I could go to the injuries and have a look at these vaccination reactions, or I can see whether, let's have a look at Metrorrhagia and see if there's anything there that comes up linked to anything else, or a menstrual disorder linked to, there's Metrorrhagia as the LLT with a PT of instrumenstrual bleeding. So it's the rhagia, meaning the bleeding, and metro there with the timing, abnormality in the timing, PT of intermenstrual. So that's what we would look for there for the in-between bleeding. So let's have a look at menstruation and vaccine. Let's see if there's anything that comes up, a term already in there. No, nothing, not surprising there. So let's have a look at our vaccination complications. I'll do it here while I'm in here, in the interest of time. See what we've got. We've got the LLT vaccination complication that we gave you. Let's go over and have a look at these in the browser. We can look at the others alongside it at the same time. We're moving as quickly as we can. Vaccination complications. So this is our HLT of vaccination-related complications. You see most of them are green there because they're actually primary to another system organ class that here. We've got a few of them just listed here which are primary things with more general vaccination complication, post-vaccination syndrome. We saw that was one of the options we gave you. So I think on balance, though, because of what we've seen with signal detection, we're not learning much by coding it to this. It's better to capture the specificity of the condition. You could argue that, well, perhaps we should select one of these, vaccination complication, and a second LLT that would capture the condition itself. But again, what are we really gaining, given that the vaccine itself is going to be captured somewhere in the case? We're going to code the vaccine, or it will be captured in the patient's records. We're not really gaining much by that. The relationship will already be captured. So of the two, my preference would be not to be looking for a vaccination-related complication that's general. If there's nothing specific reported there, we would go for the Metrorrhagia. Yep, so let's go back to our slides. So our learning points as we code the specific reported events and the relationship to the vaccine is captured elsewhere, or you could code the vaccine if it hasn't been captured. Only use a more vague term like those I showed you when no further information about the nature of the reaction is available, and we don't advocate split coding to code to one of those general terms as well. Clearly distinguish between a complication arising after vaccination and a reaction. And this is where we've said that when the body has its reaction, you get common things like fever or headache, which might be part of the immune response, but something like this wouldn't fall into that category. So we wouldn't be looking to capture one of those post-vaccination terms. So we would code Metrorrhagia as the specificity of the condition with a PT of intermenstrual bleeding, and COVID-19 vaccination only if it hasn't been captured elsewhere. So So I went through that quite quickly, Caroline, because I think it's quite straightforward once we get the principles. Any comments or questions on that one? Or
No, I think that if the vaccine is the indication for use or the suspect product, then you would anyhow capture the relationship in a separate database field. So it's not necessary to also code to any of the terms under adverse event following immunization, HLT.
Thank you. Anything you'd like to add?
No, Yvonne is asking the same question. So it doesn't, as Jane mentioned, why again wouldn't we also code the adverse event following immunization? It doesn't add any information to the case, because you would anyway code the Metrorrhagia, because this is the specific event, and you would capture the relationship or potential relationship in a separate database field.
Thank you.
So there's no need to code adverse event following immunization in addition.
Thank you. And then our third one in this is tingling in the vaccination arm. This is another one that we've received from a subscriber giving us a suggestion. They struggle with this one. Is it clear enough what's being reported here? Can we capture the connection between the tingling and the vaccination? I think that's the question on this one. And if we, what's the most appropriate LLT? If we can find a combination or not. So here's an open poll for you here. How would you handle this reported event? Someone's jumped in with tingling, injection site paresthesia, tingling of extremity and injection site paresthesia, vaccination site paresthesia. So we've got a difference of opinion here. Some of you are focusing on the tingling, maybe following the example we just gave you, where we talked about the specificity of events being the number one priority. And some of you are finding a paresthesia term relating to injection site. So the question that often comes up when we receive this question to our help desk is, can we take the arm as the injection or vaccination site? And it seems like we've got tingling and paresthesia, one with an injection site and one with a vaccination site. So which do we prioritize here? Another question we may need to decide. Anesthesia. I think that person probably means paresthesia. Anesthesia means no sensation, whereas paresthesia means abnormal sensation. So as we'll see in the browser, tingling as a condition is an LLT under a PT of paresthesia. So we'll be able to see that. So let's go back to our slides. Oh, we are in our slides. So browse. Let's have a look. So we do tingling first. Let's have a look at tingling and see what we see the placement. So having been using MEDRA for a while, I'm familiar that the LLT tingling has a PT of paresthesia. So this is something we want to bear in mind. The medical term, the PT for it is paresthesia. So let's have a look and see, is there a vaccination tingling? No. So now, because we know that paresthesia is the PT, let's do vaccination site paresthesia and see if we can find something there. Vaccination site paresthesia does exist. That's what a number of you said. And this would here, vaccination site paresthesia. Let's go and have a look at the browser to just look at it. So it is a combination term. It's available for us there. It's under vaccination site reactions. So we'd have it. So the question we're left with is the vaccination arm considered the vaccination site? And with something like tingling, We can see here we've got a number of vaccination site terms, paresthesia being one of them down here. We've got the vaccination site paresthesia. So personally, because the PT for tingling is paresthesia, I'd be happier to choose vaccination site paresthesia than injection site tingling, because vaccination site is more specific. And then the question remains, is the site and the arm, can we use those interchangeably? That is something that you would need to make your coding convention, the third bullet there. Consider having internal coding conventions, when to classify a local administration condition as a site event and when to code the condition only. This might be something that you need medical judgment on. Me saying it's the vaccination arm and saying tingling, I would be happy to code it to a vaccination site because it captures it is the same arm and it captures the relationship. So that's what I would do, is vaccination site paresthesia. Any thoughts on this one, Caroline, or comments on this?
Nothing, no comments, no questions. Good. For this one.
Thank you. So looking at the time, I see we're at 10:30 now. I think, should we give up at this one, Caroline?
Yes, I think so, because the next one will take a little more time.
The next one will take time. We've covered 9 today. We don't always get through our selection. Let's go to the end here with the let me find my, oh goodness me, right. Vaccination. Oh, sorry. This is because right, so here we are. Just as a reminder to you all that we have, we store them on the YouTube. I mentioned that. You can look at the other COVID related from January last year, similar to some we did today. You can listen back to all of those. When you open them to play it, you'll be able to see in the description the list of verbatims that's covered within that session. So that might be of help to you. We also have a spreadsheet covering what's been and explaining what's covered. So if you drop me a line at the help desk, I can always send you that if you want, and you can have a copy to see of what we did cover in each of the sessions. Now, if you have a couple of minutes, we would give you an opportunity to suggest topics for future sessions and to or if you have some verbatims you'd like us to look at in a future session, this is your opportunity. It's a survey that you can give us feedback on what you thought of the session, what you'd like us to do differently. Sometimes we're able to accommodate your requests. Sometimes, though, we have the complete contrast. Somebody asks us to make the session longer, someone asks for it to be shorter, someone asks for the terms to be easier, someone asks for them to be more complex. So we try to keep everyone happy over time with a mix. Just something to bear in mind. But sometimes the procedural comments we receive are very helpful, and we're able to restructure our session or make changes. So there's your survey. Thank you for your attention today. I realise we sent out more terms than we had time to cover. Caroline and I are also always quite overambitious in what we're able to cover, and so we will roll those forward. The next session for Let's Code will be in March, because next month Caroline is repeating her medication errors webinar and workshop. So because we've already got 2 sessions next month covering a similar format to this but focusing on medication errors, then we're not going to do a Let's Code next month. So the next one where we see you will be March, and we'll roll the examples forward that we weren't able to cover today. So I'll leave you doing your survey. That just leaves me to thank you for your attention today. Thank you for your participation in the polls. Caroline, thank you for your collaboration as always. Always a pleasure to work with you on these sessions.
Same is true for me, Jane.
So we shall look forward to meeting you all again in March at our next session. And in the meantime, stay safe, everyone, and enjoy the rest of your day. Bye for now. Bye-bye, everyone.
Thank you to all. Bye-bye.